Thank you for the invitation to be here today. I have nothing to disclose. We're all common of the prevalence of incontinence and how it affects us. It increases as age and age-related instances. The numbers in post-prostatectomy are getting better due to different surgical techniques and advances, but we also see how a variety of different numbers vary in post-prostatectomy for patients who experience overactive bladder. Those numbers can range, but typically are around 25%. Seems to be a problem with my presentation. We're missing the headings of that, but I'm just going to go ahead and include you in on that.
Thank you.
So I'm a physical therapist, and the reason to work with us is we are the muscle experts from head to toe. We do strengthening and stabilization. We do down training when patients' muscles are really tight and teach them how to relax. We do neuromuscular retraining of all muscles, not just the pelvic floor. We have a variety of different tools we have access to, from biofeedback to real-time ultrasound and other tools. We have a variety of different manual skills we use when working with our patients, and we have a variety of advanced skills, dry needling, visceral manipulation, and a variety of others. In typical treatment options when we're working with patients, we do everything from pelvic floor muscle training to biofeedback, to education on bladder irritants, scar care, scar mobilization, bladder retraining, pelvic floor muscle training with functional integration, posture, body mechanics, and lifting, lifestyle modifications, core stabilization, electrical stimulation, and many others. So the important thing when we're looking at incontinence is the patient able to contract and relax their pelvic floor muscles? And it sounds quite simple, but our patients can be very tricky and have a lot of compensatory patterns. You need to look if they're able to contract their muscles. Can they relax fully? When are they bearing down to compensate? What is the quality of the contraction? Is it an anterior and posterior lift? We look at strength and endurance. What is the timing of the contraction? My post-prostatectomy incontinence, one pattern I see quite frequently is holding breath. What type of effort are they doing? When you ask somebody to do their max effort, you miss the true isolation and you get more compensation. We look to see, are there hypertonic muscles or hypotonic muscles? What is the posture the patient works with? And is there coactivation of other muscles? We also use electrical stimulation, and there's a recent study that shows that electrical stimulation for post-prostatectomy urinary incontinence. Is it useful when patients cannot learn muscular exercises? Some patients have difficulty with the pelvic floor muscle contraction, and thus, when you look at the research, do not obtain clinically significant results. However, functional electrical stimulation may be helpful. And this is from a study from Terzoni in 2015 that it showed that functional electrical stim can help those who are unable to execute pelvic floor muscle training to strengthen their sphincter and later learn the pelvic floor muscle training. There's over 45 different muscles that attach in and around the pelvis. And due to that, it's really important that we, as the musculoskeletal experts, have to look a little deeper than just the pelvic floor, because the pelvic floor muscles work in conjunction with the diaphragm, and the transverse abdominis muscles work in conjunction with the multifidus muscles of the spine. We think about our diaphragm as the roof of our body, and the pelvic floor muscles are foundation, and we need them to work together. The pelvic floor muscles will get co-contractions from the transverse abdominis muscles as well as the multifidus. Pelvic floor muscles work in synergy with the abdominal muscles, the diaphragm, and the chest wall. When we look at the research out there, we can go back to as early as 2000 with Van Kampen et al., who proved that pelvic floor muscle training is effective. We look at the systematic review in 2006. Based on the available evidence, pelvic floor muscle training with or without biofeedback increases the return to continence more than no pelvic floor muscle training in men after urinary incontinence after radical prostatectomy. We can see Hunter et al., 2007, immediate postoperative pelvic floor muscle training increases return to continence quicker. And we can continue on. I'd like to point out Bauer et al. In 2011 showed that pelvic floor muscle training is recommended for the initial treatment of stress urinary incontinence for males in post-prostatectomy. There's also the recent Cochrane review of Anderson et al. In 2015. It looked at the conservative management, including both TURP and post-prostatectomy. And in that review, they looked at all the different aspects for conservative management, including pelvic floor muscle training with and with biofeedback, electrical stimulation, the magnetic interventions, compression devices and penile clamps, lifestyle changes, and combination of methods. And in that, Anderson recommended that, first of all, future studies need to kind of separate treatment and prevention. So they looked at over 4,700 patients, but only 2,700 had an active conservative method. And one of the criticisms was that there was considerable variation in the intervention, population, and the outcomes. So no wonder why the results are conflicting. And we looked at 50 trials met the inclusion criteria, but 45 specifically were for the post-prostatectomy male. And so we look at the value of various conservative approaches addressing incontinence after prostatectomy, and it's still remaining uncertain. The evidence is conflicting. To get a definitive answer, we need more qualitative, random controlled trials that are adequately powered and abide by the principles and the recommendations on the consort statement. So going back to the Anderson et al., the Cochrane review, there really wasn't a standard protocol for pelvic floor training. So when it shows that the evidence is conflicting, and I can tell you from everyday practice, I get very good results. This research was not having a standard protocol. Are we trying to treat everyone the same? Most of the training trials train with max contractions, and the larger studies can dominate the results. When we look at it as an experienced pelvic floor therapist or just a therapist treating for the pelvic floor training, that can make a difference. And how are we checking compliance? So if we look at one of the studies from the Cochrane review, if you look at the results, they look pretty good in a sense of, but they're showing there's no significantly different from the control groups to the intervention groups from pelvic floor muscle training to a control group of none. However, when you start looking at the actual design of the study, there were 4 sessions over a 3-month period. And they said that 92% of men in the intervention group attended at least 1 session. The end date data was collected via postal questionnaires and urinary incontinence, looking at the urinary incontinence. So when I look at that from a treatment standard, if I only see a patient once, I can tell you we're not going to have good results. If I have a patient for 3 or 4 sessions over 3 months, that's not an effective way for me to do pelvic floor muscle training. Thompson et al. In 2006 looked at muscle activation patterns. And up to that point, there wasn't much data out there looking at that. And we can see that different muscle patterns become specific to different tasks in the body, and that's proved. And when we look at tightening, isolating the pelvic floor muscles, there's a variety of different cues that are used. Most recently, it's been in research, they are told to tighten around the anus. However, recent research is showing that there's different dominant patterns that come in the pelvic floor. We have a striated urethral sphincter dominant and a puborectalis dominant. And so with different cues can elicit different strategies. And that the striated urethral sphincter responded best to the cue, shortening the penis. So when we look at this, does your patient, if we're just teaching them and we want effective pelvic floor muscle training, we really have to look at what is the best way to train the patient and ensure compliance. So the take-home messages today is obviously we need more good quality RTCs that look at all factors. With incontinence, there are many valid treatment options, but pelvic floor muscle training is recommended as a first-line treatment. And the last point is you need to individualize a program for your patient using different cues to get better pelvic floor muscle activations and addressing all their dysfunctions, not just the pelvic floor. Thank you.